Well, what a delight for me to be your Hatter lecturer. I've heard several. Puts me in a distinguished group who go out of their way to give an excellent lecture on the topic chosen. I have my hands tied because I'm the first Hatter lecturer to do it in 10 minutes. So let's get to work. What about heart failure with preserved? Well, actually, it's a new entity. So it's a new entity. If you look at all the definitions of heart failure, the word ejection fraction doesn't come in. And I'm not going to go through these. I'm going to take you through the EPI, whether it's Framingham or the European or Göteborg. Here's how we define heart failure. The word ejection fraction does not appear. So heart failure, we used to call it congestive heart failure, is an entity, and we have arbitrarily made a subgroup with ejection fraction. So let's go through that a second. In the history of clinical trials of heart failure, the word congestive heart failure, again, even in the early trials, here's consensus. I could have gone to VHF. Neither used the word ejection fraction. And importantly, they were all about all-cause mortality. The question in the early days is, can you make someone with congestive heart failure live longer? Ejection fraction didn't appear. And the answer was yes. But who are these people? Well, the word about this diastolic heart failure, preserved, didn't even enter our lexicon until the mid-60s when actually it came about from nuclear medicine labs, what were basically saying, who are these people? They're sending me people with heart failure. I measured their nuclear ejection fraction because in those days, that's how you measured it. And it's quite normal. And two publications came out around the same time in the mid-80s, and it became more something on the tip of our tongues. Yes, we know there are these people, but what about them? Well, we knew very little about them. And then we knew even less because Jay Cohn, one of the pioneers, in his very first VHF trial, analyzed the few people who snuck in or came in who had a more preserved ejection fraction, not quite reduced. And he did a mortality analysis and found that they don't die at the same rate. Now, there's nothing wrong with that. That's not a problem, but it was a problem for the clinical trialist. Then it became our problem because clinical trialists would say, if I'm going to do a trial about congestive heart failure and my endpoint is mortality, I'm going to exclude those patients. So here in the 1990s, let's exclude those patients. It doesn't mean they didn't exist, but they didn't exist in the clinical trials. Now, let me show you something. Here's the best series. We have 3 very important beta blocker studies on top of an ACE inhibitor. So here we're in the end of the 1990s. Beta blocker is good, but the endpoint is all-cause mortality. All-cause mortality. And now excluding people with a more preserved ejection fraction. So we just don't have the information. Enter CHARM. Now, I'm not doing this as though we invented heart failure, but we did put the word preserved on. We had the ability to study the whole spectrum. Now, we still were using all-cause mortality for the primary of the overall study, but we developed a composite saying that for the populations, the smaller populations, not the 7,000, the endpoint is going to be CV death or heart failure hospitalization. That's the beginning of the composite. And here's what we found. Those with more preserved, EF over 40, they had the same reduction in quality of life, but just like Dr. Cohn said, they didn't die at the same rate. Well, they did have a lot of hospitalizations, but mortality. So if you want to study this group, you can't do just a mortality trial unless it's a very, very large trial that resources are generally not available for. So event rates are lower due to less death. Now, but let's study these people. So if you're going to study them, it really starts with charm preserved. And it was not that it was magical. It was the beginning of let's look for these people. Let's bring them into the study, but we need to use a composite endpoint. And so the history doesn't go back very far. So we lag by about 2 to 3 decades of the reduced ejection fraction. And let me bring you right up to date. Let's go right to TopCat. Okay, you've seen this. There was something wrong about those enrolled in Russia and Georgia, the country Georgia. They didn't have the syndrome of heart failure. And now we know they didn't even get the drug. So let's concentrate on these. And they do have a lot of hospitalizations. They do have the composite CV death. And spironolactone in a post hoc analysis was helpful. And then it depends on you. Are you going to wait for a more pre-specified one, or is this good enough for you? It's up to you. You're seeing patients. We give you the safety. We give you the efficacy. And as far as I'm concerned, spironolactone, to be used judiciously with safety measures, is a good therapy for these people. But I'm not the regulatory agencies. I'm not the guideline writers. That's my opinion. Now, the field is moving on. So sacubitril/valsartan, very effective in those who reduced, a very proper trial with 5,000 people. And the endpoint now is the multiple heart failure hospitalizations and CV death, and shows a very, almost, but to me, this is when you have to treat people, this side of the line or that side of the 05 line is less important than there was a difference. Now, this has just been to the FDA, and they're going to be approving it. I'll show you why in a second, because it does reflect the field today. What they did was they said there's something about the people with ejection fraction over 60 where we don't see a therapeutic effect, but in those below 60, we do. And obviously, they have a whole spectrum of those below 60 because they had a reduced ejection fraction trial also. But it's not unique to sacubitril/valsartan. We see the same thing in TopCat. Something about those over 60 that they don't show the same benefit of the same exact therapy. Well, let's go back to CHARM. Same story. Benefit. Over 60, we're not seeing the benefit. So let's put them all together. Candesartan tested the whole range. Mineralocorticoid receptor antagonist, the whole range. Sacubitril/valsartan, the whole range. There's something about hitting that 60 line where we start losing efficacy. But let's look at the broad population under there. Benefit. So what are we learning? Today, you have to use your judgment, and your judgment, that patient in front of you. But I'm asked to discuss the future too, and I'm pretty bullish on it. We went from having no trials to now there are here trials over 1,000 patients. So with really clinical endpoints, we're going to have a DAPA, we're going to have another spironolactone, we're going to have an EMPA, we're going to have another spironolactone, and we're going to have a finerenone. 2021, 2024. So from not having trials, we're getting trials. So that's the short-term future, the next 3 to 4 years. How about the long-term future? I'm very bullish. We're going to be redefining the population. We're going to be using genotype, phenotype, omics. We're going to be picking out people with amyloid. We're going to be picking out people with different phenotypic characteristics. Once we show a therapy works in this group, what's going to happen is the splitters will come in, we'll find the group that needs the therapy, and we're going to be investigating people with this syndrome, finding what the appropriate bin is, and finding their therapies. Now, this is artificial intelligence, machine learning. I don't think computers are going to replace us and take care of these patients, but I do think it's going to help us identify people better matched for different therapies. So that's future. But today, you've got to use the data in front of you. You have to be vigilant. You have to understand this is real. Half of the people with heart failure have this. They can be made better. The main trick is prevent in the first place, treat hypertension, and treat risk factors so that fewer people develop this syndrome. But once they do, don't throw your hands up and don't say, oh, guidelines say there's nothing. That's not true. There are things today, and there'll be more things in the future. And I'm delighted to be your 10-minute Hatter lecturer. Thank you for your 10-minute attention.